Welcome to today's episode of the Ultimate Perimenopause podcast. Today we're speaking with Dr. Fiona McCulloch, naturopathic doctor and author of the book, 8 Steps to Reverse Your PCOS. I've known Fiona for about 15 years now, and I'm so excited for you to share your expertise and insight today. Welcome, Maggie, and welcome, Fiona.
Hi.
Thank you. It's great to be on the show. Thanks for inviting me.
Oh, it's great to have you here. I've had a number of clients who have had PCOS and not known it. So this is a really great topic.
Awesome.
So first of all, I just wanted to, get down to basics. And Fiona, if you could give our listeners a bit of an explanation as to what PCOS is and some of the common signs. So what's your basic definition?
So basically, I always define PCOS as an endocrine disorder. A lot of the time we think of it, thinking about the name being polycystic ovary syndrome, that it's related somehow to cysts on the ovaries, but it's really not. It's actually an endocrine disorder that's characterized primarily by insulin resistance or the secretion of too much insulin. And secondly, there's androgen excess, so the excess of hormones like testosterone. That's the basic definition, I would say.
Awesome. So do you mind sharing your story a little bit about how you got interested in PCOS? Because, in the naturopathic community and a lot online, you're known as an expert. And I would love to hear how you ended up on that path and how you got into your research.
Sure. So I do have PCOS myself, and I did not know that for a very long time. I had a lot of the symptoms for many, many years, including very, very far apart periods, having them around, 3 or 4 times a year. And I had very severe cystic acne, which I could not get treated with anything. I tried everything. As a younger woman in my 20s and even into my 30s, I still had it. And then I had insulin resistance, so I would always gain weight around my stomach. And but nobody ever put the pieces of the puzzle together for me. So I was going from dermatologist to dermatologist. They never really asked about my periods. And, I was on the pill on and off in my 20s. So a lot of the time I didn't really even notice them. And I kind of thought it was a good thing not having that many periods. I was like, well, this is actually a positive thing in my life. So I didn't really ever bring it up. And so eventually, I was able, after I graduated from school, I was able to get testing done, and I had a lot of the blood markers for it. And of course, then I started to put 2 and 2 together, and I went to my doctor, and they basically said, yes, this is actually PCOS. I did always have the cysts in my ovaries as well when I was younger, when they would look, with the ultrasound. So, but it was just never brought up. So, and then in my practice, I started to treat a lot of different kinds of hormonal conditions, especially infertility, for a good while. And after I did that for many years, I just started to get more and more interested in PCOS because it's just a really complex endocrine disorder. And so I just started digging more and more into it. To the level almost of obsession with it. So then now that's pretty much what I focus on primarily.
Yeah, I mean, this fascinates me for one very good reason. But there's an article on your website, and it entitled "The 14 Signs That You Have PCOS," and you state that it's estimated 50% of women with PCOS don't even know they have it. And as I sort of alluded to at the beginning of the podcast, I actually had a client myself who had all the signs and symptoms, was never tested. And then we did some testing with her, and voila, it turns out she had PCOS, and she was sort of in her early 40s at that point. So she had struggled this whole time with no answers, being brushed off. And then, in her 40s, we finally get this diagnosis, and she's like, it was just like a big weight lifted off her shoulders. So, how can we help women to get diagnosed either faster or better? Is there something that, they can ask their MD or their naturopath that, because I'm thinking naturopaths are a little bit more clued in than a regular MD. So let's say they go to their MD, what can they ask for that the MD will say, yes, okay, we'll test? Because a lot of them say, well, we don't think you have it, and we don't think, this, that, and the other. And it's like, well, no, this is what I think. Can we get this tested? So that was a long question, but hopefully that's the end.
I wish there was a really easy answer to that question, but there just isn't. But there are, because it really depends on a variety of different things. There are different tests that you can ask for. They do vary a little bit with your age. So it is really important to get the right test done at the right time. A couple of the tests that are often helpful are on day 3 of your cycle to ask for FSH and LH. Those two can sometimes show PCOS. So often the LH will be double the FSH on that day of the cycle. Mm-hmm. You can check for some of the androgens like testosterone or DHEA. Sometimes the signs of it. So they might have acne or hair loss right here or hair growth on their chin. So that they might have that, and yet their testosterone looks quite normal. One of the tests that's pretty sensitive, I would say, for is AMH, anti-Müllerian hormone. So that hormone does tend to be high. Again, that is an age-related hormone. So the older you get, the lower it gets. So you have to compare what's normal for your age. If you want, if your listeners are interested, they could go to my website at drfionand.com, and I do have a lab guide which goes through the age ranges, so they can download that guide, and it shows them, the age-related ranges. But also it shows all the different lab tests that can be ordered for PCOS, and what cycle day to take them on, as well as what's considered normal. And then the other tests that you can look at doing are tests for insulin resistance. Those wouldn't necessarily pick up PCOS because people can have insulin resistance without PCOS. But there are some tests that you can ask for which aren't commonly ordered, like fasting insulin and fasting glucose together. Or then there's another test, which is the insulin glucose tolerance test. So it's almost like the glucose tolerance test, but then insulin is added. And so we often see abnormalities there. But really the big things are the symptoms. So if at any point in your life and this often resolves as women get a bit older, but long cycles. So cycles that are, and I don't mean just the bleeding, I mean the entire cycle. Cycles that are longer than like 33 days consistently for any length of time, especially when you were younger, that's a pretty unusual thing to have unless the woman has PCOS. And then the other symptoms, as I mentioned, would be like the hair growth, on the chin, or hair loss right here, on the top of the head, and acne, which is usually along the jawline, and it's usually persists past the regular teenage acne, so it goes on into the 20s, into the 30s. So that sort of acne. And then you can ask for the ultrasound as well, the pelvic ultrasound, and if there are the multiple follicles, which are, they look like small cysts, and they usually are arranged around the outer part of the ovary. Those are also one of the signs that are in PCOS, but those do tend to resolve with age for many women, and also a lot of women don't have those. So just because a woman doesn't have those, if she has all of the other symptoms, that's more important than those cysts.
Now, just quickly, before we move on, you mentioned the ultrasound. Now, would you consider a regular ultrasound or a transvaginal ultrasound to be the most accurate?
The transvaginal is definitely more accurate, for sure.
Okay, thank you.
So I really like in your book how you've broken down PCOS into different phenotypes and subtypes, because this has been really helpful for me, because not everybody presents the same way. The way we're trained in school is the classic presentation, but especially with like the lean PCOS, I find that they're often misdiagnosed the most. And I've been, often quite surprised when I've actually done a full hormone assessment on patients with irregular periods. So I might have, a young athlete who trains for ultra marathons, and we assume that she's not menstruating because of her training, and it ends up that she has PCOS. So I love the details that you go into here. Can you explain a bit more about that?
Yeah, absolutely. So, definitely like the lean women are the ones I find who get missed the most who have PCOS because doctors don't think of them as having PCOS. But yeah, there's all different presentations, and those presentations can actually change at different times of a woman's life. So she can go from having, if say, for example, she's a runner, and is very lean and loses a lot of abdominal fat, her PCOS might be more mild at that time just because she's lost weight. But then if she goes on, to have a baby and then gains, say 20 pounds, then her PCOS might look completely different. So it's definitely a condition that really changes throughout life. And with the lean women, what the research shows is that they do have insulin resistance. It's just not easy to pick up, and it's definitely not easy to pick up with the commonly ordered tests that are done. So a lot of the time, doctors will order HbA1c. Or fasting glucose, and that looks normal. So, and the woman is lean, so they'll say, okay, you don't have any insulin resistance. But what we find is in the clinic we run a lot of tests on this glucose insulin challenge, and we find that the lean women, a lot of them secrete a lot more insulin, after the glucose drink than other lean women would. And then a lot of the studies show that there is, in fact, insulin resistance in lean women, and you'll see it more in the more sensitive tissues like the artery walls. So it definitely is there. So it's just a matter of knowing where to look and how to look for it. So yeah, and there's all different, many different ways that it can present in different women. Absolutely.
So when we look at the possibility of a client having PCOS, I was fascinated to read again on your website, and if anybody, we'll post it in the show notes. It's a fascinating website, lots of great articles. Clients with PCOS often have a history of type 2 diabetes. Also, there may be other women in the family that have PCOS, so some people could say that it's hereditary. And evidence of irregular menstrual cycles or difficulty conceiving. So if a client has these factors, what do you suggest as the first step if they're concerned that they may have PCOS and they obviously haven't been diagnosed yet?
Yeah, so if I suspect that they might have it, I would then just go through, whatever tests I think would confirm it in their case. So I might order, definitely looking at the AMH just to see if, that's really high for their age. And then I would definitely look at, detailed testing on their insulin sensitivity, just because that makes such a big difference if you can address that one factor. It changes everything, and it's the most important thing. So a lot of the time, that's one of the first things I'll do. And then, looking at once that diagnosis has been made and it's really clear that they have PCOS, it's kind of important to look at, just generally, like obviously looking at the insulin resistance is super important because it improves everything. It also prevents all the chronic risks that are associated with PCOS, but then also looking at what's really important to them. So if they're, really, really suffering with, acne, or if they're losing a lot of hair, then we can start focusing on, what are their goals, or what's the part that's stressing them out the most about PCOS, because for each woman that might be different. Or if, a woman is trying to conceive, that might be her goal.
So I'd love to hear your take on nutrition for insulin resistance, just because there's so much out there in terms of paleo and keto and low carb and all of this stuff. I'd love to hear what you recommend with your patients and clients, and whether that varies depending on their presentation and goals as well.
Yeah, so it definitely varies for each client, and I'm kind of agnostic about any of those different types of eating plans. So I don't really feel that one is better than the other. What I do is I use something called the food insulin demand, which is basically a metric where we actually have information on how much insulin we need to process a given food. And so I will structure a meal plan for them based on keeping their insulin secretion controlled after they eat, and then also keeping their blood sugar balanced, because a lot of women who have PCOS have a lot of problems keeping their blood sugar stable. they have high insulin, and so that causes their blood sugar to basically go into a roller coaster where it goes up and down. And then, the only solution to low blood sugar is to eat sugar and carbs. So a lot of this is about keeping the blood sugar balanced. And then I also tend to follow a more anti-inflammatory approach where, we're minimizing dairy, gluten, and any foods that they react to, and of course, sugar. But I know it's for women with PCOS, it's a long game. So I don't, and they're usually they don't have a lot of food sensitivities. It's not part of the disorder. So being super strict is not as important as eating so that your blood sugar stays stable so that you can keep eating well for the rest of your life.
Being a nutritionist, I completely agree. And I'm absolutely fascinated at the moment with insulin resistance. It's something that's taking up a lot of my reading time because it's so important. And I think it's overlooked in probably just everyday life. And in particular with perimenopausal women, it's really important. So
absolutely. Yeah.
So how might the perimenopausal years and the hormonal transition be different with PCOS? Because you say that things change over time as a woman ages. So, a woman has estrogen dominance, for example. What sort of changes would you see if she had PCOS?
Yeah. So at perimenopause, it's really quite a little bit different with PCOS. So first of all, women with this condition tend to go through menopause later. Mostly because they have more eggs in their ovaries, but also more testosterone. And so that causes menopause to happen a little bit later. And a lot of women think that, okay, when the ovaries are now quiet, there's not going the PCOS is gone, but it's really not. All the research shows that it's still there. There's still the tendency to secrete more androgens than average. Of course, the levels do go down quite a bit. And then the insulin resistance actually gets worse. So women with this condition are much more prone to having weight gain around the stomach with menopause. They're much more prone to getting type 2 diabetes, cardiovascular disease. So these are the risks that it's actually even more important to focus on your PCOS when you go through menopause and for those later years and know how to eat. Because it's really not a reproductive disorder. And that's why I always like to call it an endocrine disorder. It's not a reproductive disorder. It's been thought of like that, and it's been thought of as an infertility type of condition. Yeah. But it's really not. Yeah, it's more of an endocrine disorder with insulin resistance and the tendency to, develop things like type 2 diabetes. And a lot of even younger women do develop that who have PCOS.
Interesting.
So would the high androgens, like the high DHEA especially, could that lead to maybe an easier menopause transition? So being less sensitive to the drop in estrogen? Because when I'm working with women with menopause, I often check their adrenal hormones and their DHEA levels, especially as a predictor of how sort of quietly the menopause will go. So I'm curious what your observations are.
I think, for the ones that have high DHEA, because not all women with PCOS do, but those ones, I do think they actually have an easier menopause. And so I always try to tell them, this is actually one of the good things about having this kind of PCOS, because menopause comes later. It's a little bit easier. They can also retain more muscle mass and bone density as well. So it can be easier. But then there are some women who are just really, that drop in estrogen can just, it's so variable, as I'm sure you both know. Sometimes you just can't tell. There are certain women for whom it's just awful. So I think that can happen to women with PCOS too. But I do think that they're the ones who have high DHEA have a little bit of an advantage there.
Interesting. So, so going back to insulin resistance, because again, I'm fascinated by it. Particularly women who are entering perimenopause, they do get that, and you alluded to it before, they do get that fat around the middle. So, how can they cope with and reduce that? Because they've got kind of a, twofold thing. They're going into perimenopause or potentially into menopause, and they have PCOS. Do you recommend things like intermittent fasting, perhaps? I know we talked about some dietary things before, but maybe intermittent fasting is something you can elaborate on?
Yes, so absolutely. The one thing that to know about PCOS is that it's a condition that basically remained in our genetics for a certain reason, and it makes women less fertile. So you have to wonder why, would we still have this gene if it makes you less fertile and it gives you diabetes? But the reason is that it's the genes that help you survive famines. So the women who have PCOS, when there would be a famine, they would have so much fat stored that they would survive and also even be able to have babies during the famine. So when we think about that, the women who have PCOS, their metabolisms are kind of really smart and always find a way to store energy. And we find that, you can eat something a little bit off, and if you have PCOS, you gain weight right away. And it's very frustrating because you'll see a lot of women trying all these different kinds of diets. And, eventually they stop working because their metabolisms are just too smart. And they're like, nope, we're not doing that. We're just going to start storing energy now. So a lot of what tends to work is eating a certain way most of the time, but then kind of mixing it up a little bit and tricking your metabolism, because if you keep doing the same thing, it'll tend to get kind of smart to that. So definitely something like intermittent fasting or time-restricted feeding can be really helpful. So eating within a certain window, then you're getting a longer time without insulin release, and so then your cells do become more insulin sensitive. But then there's other types of ways that you can, I often recommend like switching it up a little bit. So you could do something like 2 days on, a lower calorie kind of program, and then 5 days higher calorie. So, just switching it up is really, really helpful. There's also things like the fasting mimicking diet, which is, really low calorie for 5 days. So I really recommend that because, just trying a variety of different types of, evidence-based nutrition, always with it in mind that you're wanting to keep your insulin controlled. Keto can work for some women. I consider that to be more of a last resort because it causes low insulin all the time, which is not really the goal. Our goal would be to have normal insulin after we eat and not just flatline insulin, because insulin does have certain roles in our health and in our body. But there are some women for whom, for example, who will, like, that is the only thing that works. And if that's the case, then that's great. I'm all for that, because it's definitely a tough condition to try to deal with diet.
Yeah.
So what about stress and exercise and other factors that can amplify PCOS symptoms? How do you approach those?
Yeah, so exercise is really important for PCOS, more than I would say for many other conditions, because it definitely increases insulin sensitivity. And then the more muscle mass you can build, the more insulin sensitive you're going to be. So that's beneficial as well. And so, definitely strength training or high intensity exercise is always really helpful, just for maybe, like a HIIT training for 20 minutes. Those are ideal for PCOS. And then when it comes to stress, I think it really does impact the condition quite a bit, especially if the woman has the adrenal androgen type of PCOS. So for women who have that, stress makes, it actually raises the level of androgens in the body. So that's directly correlated. But then we know that like not getting enough sleep causes more insulin resistance and more weight gain. So it's definitely a huge, huge part of working with women with this condition.
Yeah, it seems to me that, a lot of the things that we go through in perimenopause are actually kind of mirrored in PCOS in lots of ways. So we see the sleep thing and the insulin resistance and the exercise. So yeah. Can you tell us a little bit more about leptin resistance before we move off, insulin resistance completely, but leptin resistance as well?
So leptin is a hormone that's secreted by our fat cells, and it basically tells us, it gives us the feeling that we've had enough to eat, basically. And when you're insulin resistant, you actually also become leptin resistant, which is very unfortunate. So it causes the signals of being full to be really messed up. So a lot of women with PCOS really have trouble telling when they're hungry or when they're full. And I even remember as a teenager not being able to finish, like to stop eating. I would just keep eating like for a really long time, like just eat carbs for, and I wouldn't be able to tell that when I was full. And until I really changed the way I eat, now I can tell when I'm hungry and full, but it's not, those pathways are really, really involved in PCOS. And that's why there is a lot more problems with binging with the condition, and that contributes definitely to the insulin resistance because it causes a lot of weight gain and blood sugar, because it's like a cycle of where everything in the whole body and the brain actually is impacted.
Yeah, because when we talk about binging, we're not talking about binging on cucumbers and tomatoes and salads, right?
No.
It's all of the other stuff.
Yeah, mostly carbs, I think, for most women, or sugar are the ones that women tend to binge on who have PCOS.
Mm-hmm. Yeah.
Okay, so let's go on to excessive facial hair and signs of high androgens. So I would love to hear how you approach this beyond nutrition. I know nutrition is an absolutely huge part of this, but I mean, we see a lot of, changes in facial hair in women without PCOS around menopause as well. So I'm assuming it's, even bigger and more dramatic in women with PCOS. So what are some of the things that you've found helpful?
Yeah, so outside of, all the nutrition, which obviously plays a role, so this hair growth, which is called hirsutism, is a really big problem, actually. And once the unfortunate part about this is once the hair has grown, there's nothing you can do except for to have it removed with, laser or another approach. But you can actually do some things that will reduce the growth of the hair or make it less thick. So one of the favorite things that I like to recommend is spearmint tea. It sounds really simple, but there's research on using spearmint tea for hirsutism. And what I usually recommend is for women to take 3 tea bags of spearmint tea and to put it in a big tumbler of where they can put some hot water in there and just fill it all up, because I find it's very hard to remember to drink 3 cups a day of spearmint tea. So this gives you the same amount. And then, you just do it in 1 cup and drink it throughout the day. That's a really basic, it sounds simple, but it actually works for hirsutism.
Yeah, I've never heard of that before.
Yeah, it's really surprising that it works that well, but most women do see a reduction, and I can't imagine it wouldn't work for women at perimenopause who don't have PCOS, because it would be the same kind of mechanism by which the hairs are growing there.
Does that also help with acne if it's hormone related too, or no?
It does, actually. Yes, it does help with acne. And then the thing with acne is it's a little bit different. It's a little more complicated kind of condition. So because it involves anything, when your hormones change, acne gets worse. So a lot of the women, when they don't, if they don't ovulate and then they start ovulating, then their acne gets worse, so we're improving their hormones, but now their acne is getting worse. So you have to sort of have to break the cycle. And I find with acne, you have to do a combination of topical and also internal treatments, especially for the androgen excess type of acne. And then once it's under control, it's a lot easier to deal with. But at first, when it's super inflamed, a lot of the time something like spearmint tea probably wouldn't be enough to deal with that, but it would definitely help with the androgen levels and the effect on the skin.
I wonder if you could use the tea bags cooled on your face to control the inflammation potentially.
You probably could, because a lot of the mechanism of action of spearmint is the antioxidants that are in there. So you definitely could. I tend to be very basic with that, and I recommend tea tree oil, because it just has so much evidence for acne, and it works so well, and it's so easy to get, and it's strong. So I tend to recommend that, and then something to exfoliate, something like an alpha hydroxy acid. To stop the blockage of the pores topically. And then, I always warn women, if you're not ovulating at all and now you're going to start ovulating, your acne, and you have acne, it's probably going to get worse, but we'll work on it and deal with it. Because once you start ovulating more normally, you're going to have less androgen excess. So over time, the acne will improve, but you usually have to do more topically at first. And then another of my favorites for acne is N-acetylcysteine, which is a supplement that is an antioxidant. It just really improves the integrity of the skin. It reduces inflammation, and it's just such a great supplement for all the different elements of PCOS, but especially as well for acne.
Interesting. So let's talk about sleep a bit for a moment. You mentioned that research has found that women with PCOS who are the most insulin resistant are more likely to have obstructive sleep apnea. And I'm finding this a lot in the groups that I have. Is sleep apnea seems to be either on the rise or I'm just noticing it more. So, how can you deal with that along with everything else? What would your suggestions be?
Yeah, sleep apnea is so common in PCOS, and the incidence of it goes up. The more abdominal fat that you have, the higher the incidence of that. And there's definitely a compression of the abdominal organs, the nerves, and so again, going back to those very basics, the number one thing you can really do is to work on the insulin resistance, and work on just getting that abdominal fat burned. The good thing is that as soon as you're less insulin resistant, that's the first place that the fat will come off of, is the abdomen. So it is a lot of the time, even if you can, reduce your waist circumference by 2 inches, that's going to do so much for sleep apnea. And I always tell women, like, don't worry about the scale, but measure your waist. Like, that's the most important thing to look at if you're wanting to track a metric to see how you're doing. A
number of women, maybe it was in the 80s, but a number of women try to target certain areas, right? They try to target the stomach, they try to target the legs, that kind of thing. But we were always told that that's the last place it's going to go. But
yeah, I remember the 20-minute workout, like them doing those sit-ups.
Yeah. Oh, yeah, this is going to get rid of just your stomach if you do like 20 minutes of sit-ups. No, that doesn't work. So that's nice to know that, if you have insulin resistance and you're working on that is actually a place that you're going to start seeing some results, because that's what women want, right? They want to see results. Yes, they want to feel it.
Oh, yeah.
They want to see it.
Oh, of course, right? Yeah, and definitely doing any kind of exercise on that area is not going to do anything at all. So it's really about just lowering the levels of insulin and getting that insulin resistance to drop, and that fat, because high insulin stops us from burning fat. And so that's one of its major roles. The first one is to store fat, and the second one is to stop you from burning fat, which are two things that are not optimal to have high all the time. So once your insulin goes down, that fat actually is the first to go. So that's actually really reassuring when women change their diet. They see that right away.
Now, I have been reading that if you are obese, for want of a better word, that it does obviously take you longer to get that under control. I know we're kind of going away from PCOS a little bit, but some women who have PCOS are obese and they also have sleep apnea. So they're dealing with a number of things here. So, from sort of being an average woman with insulin resistance, PCOS, excess stomach fat, on sort of how much longer would somebody who was obese would that take? Because, I think it's very important for our, with our clients to sort of give them realistic expectations that, yes, it's going to take longer. I don't know if there's a statistic or, some kind of measure that, it will take you X amount of time to lose that, but you will lose it. Or is it a question of they won't?
It's a lot harder, that's for sure, and it takes a lot longer. And the reasons for that is that our brains really change when we've gained significant amounts of weight. And so you're kind of fighting against your brain wanting to go back to that weight. And when you get the insulin to be as normal as possible, unfortunately, when there's a lot of excess weight, the insulin resistance continues. And so for some people, that's where, they find the ketogenic diet can be helpful, because it definitely lowers the insulin, and sometimes that's the only thing that will lower it. So everyone is a little bit different, and it depends on if they're able to exercise and, put on some muscle mass. Fasting can be helpful, but it would have to be medically supervised, different kinds of fasting. And then there's a certain set point that maybe that's where you're going to be, right? It's not going to be in the optimal, most ideal body mass index, but it's going to be a lot better, and when you go beyond that, you get into kind of starvation mode. So it's just a lot of suffering, right? So yeah, so I think it is harder. And so just kind of setting those expectations where, we're going to try to, and the other thing I should mention is it depends how long that person has had that weight on. So if it's been for like 20 years or a really long time, that's a lot harder to deal with. Whereas if it's been like a weight gain over like 2 or 3 years, like that person could often go right back to where they were. So I think, yeah, it really depends. And it just takes a lot of patience and just keeping going and not comparing yourself to anyone else, but just to where you were, where you are, and know that, that's a huge improvement.
Excellent.
So to summarize, I'd love to hear what are your top 3 tips that you would offer a woman with PCOS who's starting to notice hormone shifts with perimenopause. What would the 3 take-homes from today be?
I would say definitely go and have that insulin glucose challenge test done. Basically, if you want more information on that, I have a whole article on it on my website, but it'll give you a good baseline as to where you are when you're starting, and then you can, measure your progress going forward. I would say as well, make sure that your meals have protein, lots of vegetables, and healthy fats, and especially food sources of healthy fats, so like olives, avocados, nuts, and seeds. And then variable, like just keep the carbohydrates under control at each meal. A smaller amount is fine, but don't let the carbs be the main star of the meal. And and then exercise. So especially strength training, I think is so helpful, especially as we get older, not only just for PCOS, but also to keep our bone density, to retain muscle mass as we get older, which is really important just for aging. So I think that's one of the most important things that you could do at perimenopause.
I would completely agree with all of those.
Yeah, me too. So I see your book behind you, and I just wanted to mention that today. So it's a really amazing resource. I recommend it to almost all of my patients who I speak with PCOS. So it's called 8 Steps to Reverse Your PCOS. I would highly recommend that. And can you just mention your website again so that people can find you online?
Sure. It's drfionand.com.
Perfect. And we'll put that in the show notes as well.
Awesome. So thank you so much for being here. I always learn so much from you, and I'm grateful that you came on with us today to explain another perspective of perimenopause to our listeners, because I mean, as we started in the beginning, there's a lot of women who may not even know that they have it. And, dealing with insulin resistance through our 40s and 50s is something that I would say the majority of women have to start thinking about. And this has been so helpful for me as well.
Yes, thank you. It's been amazing. I've learned a lot today.
Well, thank you. And I am so excited for you with this show. I think it's such a great idea because I think as women, I'm heading into those years, and I think this is something that we can all benefit from, just learning and sharing information. So thank you guys for having me on the show. I really appreciate it.
It's very nice to hear things like that. Thank you. And hopefully, I'm sure that this particular show will get a lot of airtime because, as we said, people are maybe thinking that, I think I might have this. Listen to the show and then go straight to their MD or their naturopath and start to research it. So we may even be having you on again, which would be amazing if you would come on again.
Oh, thank you. I would love to.
Awesome.
All right. Well, thank you so much for joining us. Please subscribe to our podcast, like the episode, and we'll see you again next week.
Sounds great. Bye.
Bye.